Hello and welcome to Your Health in Your Hands and Happy New Year. Welcome to 2024. I'm Dr. David Ajibade with the Brain and Body Foundation. And if you remember, many years ago now, 2018, our very first episode was about heart disease, in general, cardiovascular disease, and how important it is for us to have healthy arteries and veins. Arteries are the blood vessels that take blood away from the heart. Veins take blood back to the heart. Nothing is going to work if your arteries and veins are not working well. Because all our cells depend on oxygen, all our cells depend on nutrients to do the work that they need to do, and they have to take waste materials and debris, other things that are toxic to the body. The veins need to take them away from the cells and the tissues and the organs. So our cells and tissues and organs, like the brain, like the lungs, like the liver, they all need oxygen and nutrients. Then once they've metabolized or they've broken down these oxygen and nutrients, they create waste products. Those waste products need to be taken away for them to be healthy. And this process is done by the arteries and the veins. The greatest disorders, the worst diseases, the number one cause of death worldwide is as a result of things going wrong with the arteries, specifically arteries, and to some extent the veins, but it's primarily with the arteries. We've discussed also that Africans, people of African origin, Black, dark-skinned people like you and me, have the highest rates of cardiovascular disease in the world. Now, we have higher rates of a lot of other things as well, like cancer, but we want to focus primarily on cardiovascular disease. And what we're beginning to see is that we're beginning to see these problems arise even in younger age groups. So in short, for you to be healthy, your first priority, your very number one priority, is to have healthy blood vessels, specifically healthy arteries. And we're going to be talking about that to some extent. On our show today, our special guest is Dr. Nelson Aluya, who is in fact, why don't we just bring him on? Thank you for joining us today, Dr. Aluya.
Yeah, it's a pleasure. Sorry, my camera is beginning to act up a little bit. It's a pleasure to be here. Thank you for having me, David. It's a pleasure.
Absolutely. Well, just tell us a little bit about yourself. Let's know your interests before we get into this topic.
Well, first, I currently live in New Jersey, here in the United States of America. Originally from Nigeria, born, bred, educated primarily. I went to the Great Ahmadu Bello University where I graduated from medical school and then immigrated to the United States. Not necessarily out of Jacquism, but as a result of seeking the desire to become one of the best in the area I've chosen to become, which is medicine. So, and I always tell people this, if you want to be the best, you must go where the best are. And as at that point in time, I think till now, the United States is still about the best when it comes to medicine and the technology involved in the medical practice. So yes, I did come here over 20 something years ago now. And then all through did my residency, trained in both medicine and pediatrics. So I'm double trained. I often joke and I say I'm two doctors in one. So I take care of babies all the way to, adulthood, 100 years old plus. I eventually became an assistant professor at the New Jersey Medical School, Rutgers University, and then became until a month ago, I was the chief medical officer. That's the CMO, which is equivalent to CMD in Nigeria, that they say, of a federal health qualified center here in the state of New Jersey. It's called the Newark Community Health Centers. It's a federal health qualified centers where we provide healthcare for communities that are designated as almost indigent. However, we also provide care for the whole entire community. At that point in the level, I managed 7 centers with clinical sites where we provide care for the community. But outside of that, I call myself a medical advocate. I advocate for medical issues that concerns us, not just with the people we serve medically, but also in the community, the Nigerian American, the African diaspora, or the African um, Black community here in the United States and across the world, really. Outside of that, I was the chair of the state chapter of the Association of Nigerian Physicians in the US, which is AMPA. And I was also the president of the New Jersey Medical Association. So under that guise, I was in Congress to advocate for the Black community in terms of diabetes care, increasing the number of residency training, especially for people of color or Black people. But then presently, on the other advocacy aspect that I do, I am the president of the Nigerian American Public Affairs Committee, NAPAC USA. And at that point where we identify, support, educate, and engage the Nigerian American community in the areas of policies and politics. We also do that in the area of health, advocacy, youth empowerment, and women empowerment, as well as STEM. So that's all some of the things I do. My hands are full. On that capacity, we help to bring individuals' interests in the space of US politics. So we're the ones getting people getting elected to the US um, um, political system so that we can engage them and truly show that we're here to stay, but at the same time, advocate for our community as a whole as well.
Fantastic. So you're operating in two worlds, actually. You're
Yes.
operating in, I don't know how you do it, man. Where do you find time to sleep?
Well, like they say, the harvest is plentiful, the workers are few. So the few workers have to work extra. And you know, just like you're doing, you're taking charge and leadership in your space to bring knowledge and information to our community that will save lives and livelihoods.
Indeed. Well, it's so been the only way we've been able to do it is through the help of people like you. So let's get into this. Cardiovascular disease, in spite of all the huge leaps and bounds that have been made in the Western world, we're still seeing inordinately high levels of cardiovascular disease and hearts and really deaths from heart attacks. Although I would say, would you say it has reduced in the Western world somewhat? I know it hasn't reduced in the third world countries, but in the Western world, what's your impression?
Well, cardiovascular had, diseases like you just mentioned, and in your introduction, we talked about cardiovascular, meaning vascular, arteries and veins, as well as the heart, and including the brain. That's basically what the cardiovascular system comprises of, and it's still the leading cause of death here in the United States. On the average, about 660,000 people die every year from cardiovascular disease, followed by cancer and every other thing. The only other thing that came next to it was in 2020 when COVID ran up to 620,000 people dying in that year in the United States. So it's still the leading cause of death. And globally, it's still the leading cause of death globally around the world. I think the WHO in their latest report gave 17.9 million people dying from heart disease across the globe, of which 4 out of 5 of those people actually died from ischemic heart disease, meaning disease of the heart itself, where the heart stops because of one reason or the other. It hasn't abated, unfortunately, despite the amount of money that has been put into curbing or addressing the issues and risk factors for cardiovascular disease. But we'll dive into some of those reasons particularly. But one of the things that we often say, and when we look at data and data how it is, in the United States, saying those numbers and the risk per race, but when it comes down to those of people of color, especially Black and brown community, is so much higher than all the other people, other races, meaning the Caucasians, Indians, Hispanic, the Native Americans. Blacks are 4 to 5 times higher risk of cardiovascular disease compared to some, the other races. So it's a big issue that concerns us. But we'll dive into some of the reasons why it's happening and what are the steps we need to take to addressing this issue so that we can truly save lives as well.
Yeah, absolutely. And that's a tragic number. I had the impression that there were in the US we were beginning to get a handle on things, and so we're able to even if not provide high quality life, but at least keep heart attacks from happening. Like I said, even if the quality of the cardiovascular system was not the best, at least keep heart attacks. But what you're saying is that even at that, even with all the technology and all the screenings and everything, we're still not there yet, where we're still having heart attacks and strokes like before.
Yes, just thereabout. And I'll tell you, the biggest contributing factor to that, if you take a time span from the 80s to where we are now, basically obesity and diabetes, period. There's no single talk way around it. And if you look at the history, I've given talks as well on diabetes, which is a great area I'm really interested in. From the 80s to about 2016, the obesity and diabetes graph would look exactly the same. They were exactly the same. So the rate of increase in diabetes was exactly the same as the rate of increase in obesity. Now, up to 2016, obesity plateaued a little bit, but diabetes did not. It's kept on going up, and it's still going up, unfortunately. And if you understand what diabetes is, it affects the brain and every other tissue or every other system or tissue in the body. And that is an increased risk in itself of cardiovascular disease outside of just diet and sedentary lifestyle. So it's a huge contributing factor. And if you bring down to the Black and brown community where people look like you and me, that risk is so much higher, and the propensity or the incidence of obesity and diabetes in the Black and brown community is even so much higher than every other race as well. So we can tie both together as we continue to talk more about it.
Okay, so obesity, diabetes, those are big problems. It's also happening, obviously, in places like Nigeria, which has the largest number of Black people on the planet. But also we have, I just found this out, Nelson, we have the most number of people living in poverty on the planet. Did you know that?
Yes, I do.
So those ones who are living in poverty cannot be obese, I don't think, right? And they're not eating fast food, so that's for sure. Fast food is a luxury in Nigeria. Fast food in the US is a necessity. I mean, it's not a necessity, but it's the food of the poor and the low income people. Right. So what else is going on? Because in Africa, Nigeria, the rates of heart disease are rising as well, but they're not eating fast food. What is going on, and what can be done? I know we're living longer, so the life expectancy is increasing. But like I was saying in my opening monologue, it's like we're seeing heart disease increase. When I had this Professor Anuma, she's an endocrinologist, and she was talking about how they would go and do just like spot checks in schools. They'll do their blood pressure measurements, they will do their blood sugar measurements, and she'll find out these kids are already having high BP and high blood sugar. And to me, I don't think you will see those kind of results in schools in the US, which are predominantly white, maybe among the Black schools. So it has to be something that is beyond just environmental, that is probably more intrinsic to us and more genetic, that is making us more prone to having cardiovascular disease. And the sooner we begin to put the spotlight on it and explain exactly what that means to the lay person now. Doctors need to be aware of it, that's for sure, but the lay people too need to be aware of their risks and why that is so. So let's discuss that a little bit. Why is it that Black people have such higher rates of these conditions?
Well, I'll tell you this, and I'm glad you brought that up. From genetics to and the environment and all that. And I'll use one singular word first before I go into the details of it. Epigenetics. Epigenetics is a new term that got really popular recently within the last 10 years, but it was actually first described in the 1970s. What it means is the environment where you live has a way of affecting the way your DNA expresses itself. It does not change its DNA in itself. It does not change the core fibers of the DNA. It changes the way the DNA expresses itself, meaning the enzymes that the DNA constitutes for, the environment where you live can affect that. And as it affects that, it expresses certain things, meaning the risk of diabetes, the risk of you having high blood pressure, the risk of you becoming obese, the risk of you with cardiovascular disease. That's how it is. Now, putting that in our mind, we need to begin to draw inferences from different ends and tie them up to how our environment is changing how we perceive disease, how we view disease, and how the disease affects us and the steps to which to handling those diseases. And this is really very profound. And one of the things when I told you I'm a medical advocate is that I pay attention to not just the environmental factors anymore, but also understanding what are the genetics that are out there that we inherit that are affecting our risk for diseases, including cardiovascular disease. Now, you brought the issue of blood pressure in children. They did a landslide study, I think, in the 1990s, where they took blood pressure across 51 countries for over 3 million children. And they realized that the blood pressure, because most pediatricians, I'm a pediatrician as well. Unfortunately, we don't check blood pressure up till age 10. And thus we begin to pay attention to, checking blood pressure and all that. And unfortunately, they now realize that a lot of those children at age 10 tend to have high blood pressure as well. And these changes that take place in the small vessels of the heart and the body, the effect of blood pressure actually start really, really early. Down the line to a point where by the time you become an adult, to age 40, 50, that's when you begin to see the true effects of high blood pressure, consistent or unabated high blood pressure over time. Now, drawing that again to obesity, we know that the obesity rate here in the country, like I said, in the US, starts skyrocketing in the 80s. And that, again, has to do with the lifestyle and the policy changes that came around this lifestyle when we now start having more GMO, genetically modified food with the kind of sugar, polyunsaturated sugar that was introduced into the food that people eat. And that increased the incidence of obesity, and that took on to what we now have today. Now, in pediatrics, if you're obese at age 10, the chances of you being obese for the rest of your life is up to 60 to 70% if you're obese at age 10. So, and that's why we must pay attention to obesity, even in Nigeria right now, on the entire African continent, because where the US was in the 1980s, we're just at the beginning of it right now. We're right at the cusp of it. And that's why we must begin to take cognizance of this, and everybody has to be involved. You, me, those in the diaspora, those in healthcare policies and management, the non-governmental organizations, we need to begin to sound the alarm. And I'll tell you why. I begin to see the obesity rate, in as much as we're still the poverty capital of the world, the obesity rate is still increasing. You know why? Because our lifestyle is changing. Where we prefer to eat foreign or important food that only God knows where they were made from, and all the components that were put to preserve them 5, 10 months or a year or 2 years ago, before they got brought into the United to Nigeria. I was talking to somebody the other day, and she was telling me about the food that they ate and how nutritionist and all that. I think she was eating grapes and all that, and telling me how nice it is because it's healthy. And asked one question. I said, "What's the expiration date on the grapes they were eating?" She's like, "Oh my God, oh my, I don't even know." And this is a very bright, educated woman. I said, "Okay, take a look." She looked, there's no expiration date. So how many of us truly pay attention to the expiration date of the food that we eat? The canned food and all the things that are important. Because I often joke and I say this, those foods are new to your DNA. That's not the food your grandpa, great-grandmother ate. They ate stuff that came from the ground. And that's why when we kept the food back home, I grew up in Nigeria. If you kept the food on the ground and not put in the fridge overnight, 2, 3 days, they're rotting. The food we eat these days, you put them, they're still there because they've been fortified and preserved to keep a shelf life, meaning the number of days it can stay before they get rotten. And they infuse those things with products that will keep them there. Because at the end of it all, it's maximizing profit. Now, let me bring it down to the nitty-gritty of why this is important. There's a study, look it up. Diabetes and obesity, especially diabetes. And I'll tell you, and I'll bring into the genetics of some of these things as well. In the 80s, Africa was described as a continent without diabetes. In the 80s, not too long ago, in the 80s. Now, by 2016, when WHO and the CDC, Center for Disease Prevention here in the United States, declared diabetes as an epidemic. 2016, because they now understood the global impact of what it is that is affecting what diabetes is doing to all of us. So it was declared an epidemic in 2016 by the WHO and CDC. Now, as at that time, globally, there were 383 million people estimated that had diabetes, 380-something million. Africa, at that point in time, was just about 17 million. But guess what? By 2020, that number had gone up globally to about 420 million. The US at that point in time was about 32 million. By today, Africa then was about 19 million. Today, the incidence of diabetes around the world is about 470 million. And that number will get up to 770 million by the year 2030. So you see diabetes on the march. It's an epidemic that's here, and we must pay attention. But I'll tell you this, Africa, from 2016 to where we are today, that number had gone up to about 23 million, which they say they found. Now, Nigeria, supposedly, by statistics I know is grossly underrepresented, was about 9 million diagnosed. We know those numbers are far less. When I schooled in ABU, we never truly treated diabetes. The ones we saw in Nigeria then, which is about almost 25 years ago now, the number we saw then were basically people who had type 1 diabetes. That number has increased. Now, if you put all that into structure, one of the things I'm beginning to hear right now in Nigeria, tying up cardiovascular disease, diabetes, is kidney disease, kidney failure.
Yeah, it's on the rise for sure.
The number 1 cause of kidney failure in the world is diabetes. The number 2 cause of kidney failure in the world is hypertension.
Yeah.
We had hypertension as a big issue in Nigeria, which is usually hemorrhagic, But here in the United States, it's impacted. What that means, those who often have strokes in Nigeria were because the high blood pressure was so high, the pressure was so high, the vessel in the brain will burst. That's hemorrhagic strokes. That's what we basically saw, not infarctive. But here in the United States, the kind of strokes that people had was infarctive stroke, meaning a blockage. And that blockage was because of high cholesterol and all the other things that took place. But we begin to see high cholesterol in Nigeria now, not just hemorrhagic strokes anymore. We begin to see infarctive kind of strokes. And as that increases, so also you see the infarct, meaning the cholesterol and all the debris that's taking place, that begin to block the small vessels that supply the heart. That's what you get when you get a heart attack. Why are we having this? One, because the amount of cholesterol that we now have has increased in the general population. Do we have statistics for that? Probably not. The amount of diabetes that's happening in Nigeria has also increased, and as well as the attendant affectation of diabetes, meaning strokes, heart disease, kidney disease, amputations, that number has increased. Why is it like that? Because diabetes in itself, what it does, it actually affects the small vessels, and it changes the small vessels and begin to make them thicker and increase the debris within the small vessels, so that the small vessels under normal circumstances can expand and contract. But with diabetes, it stiffens it so that it cannot expand when you need for it to expand. Meaning, for instance, if you increase your activity, it increases, it's not expanding. So it gets stiffened, and the risk of it getting blocked is so much higher. Now, add that to obesity. That's what we're talking about, a big issue. Now, down to the food, tying the food that we eat and all this foreign food that is new to our DNA. And I always say this, diabetes was new to the Black DNA. It was. But tying that to the food and the increasing risk of cardiovascular disease in our community. Because the data, I think, by circulation, there's the article that was written because circulation, where they gave data, I think, about 590 per 100,000 risk of cardiovascular disease in Nigeria, meaning out of 100,000 people, 595 of them get cardiovascular disease, meaning strokes and heart disease. Now, when you put down the food that we eat, when we talk about these foreign foods, some of the type of sugar that's in there, I don't want to use technical terms. Some of the type of sugar and glucose that's in those kind of food, because of the way they preserve them, actually reduce what they call the HDL. Because if you look at the cholesterol, cholesterol is based in multiple areas. There's a total cholesterol, there's a bad cholesterol, which is the LDL. So anybody who goes to the doctor needs to go ask, what is your total cholesterol? Anything above 200 is said to be bad. Now, if you look at the bad cholesterol, LDL, that is the one that increases your risk of heart disease or cardiovascular, because it lines up with the walls of the arteries. Now, that number should be less than 100. Anything that's above 100, 150 and above, increase your risk. Now, the one that's most important that we must pay attention to is what they call the HDL, the high density lipoprotein. And that is the one that's cardioprotective, meaning if you have a higher number of that, the risk of you having heart disease is so much less. Now, when we look around us in the Black community here, when we look, majority of us in the Black community here in the United States tend to have a lower number of HDL. Now, that HDL should be higher. The higher it is, if you get 50 and above, especially if you're a man, the risk is much less. For female, about the same thing, 45 and above. Now, what happens to that food, which we'll begin to pay attention to, especially those of us of color who are Black, especially Black doctors, we need to begin to pay attention to these things. We realize that those kind of sugar. There's a particular kind of sugar that we now have that has been produced out of wheat. And all the things that we use to make the food that we eat now actually decreases that amount of HDL in us, people of us who are black color.
Wait,
Now, however,
hang on, jump in. Let me jump in. Say that again. So, because of wheat, did you say, or I mean, what is causing that? What is causing us to have lower HDL than white people? Did you
so
explain that again?
there's a type of glucose, a type of sugar. I think it's called lyco. I've forgotten the name now. I'm having a brain block.
Okay.
As compared to some kind of glycogen, I remember. But
Not
it actually
lipoprotein.
it actually reduces the amount of HDL that we have in us. The more of the food that you consume that contains that product, it reduces the HDL. Now, before that, right, what the narrative that was pushed around here in the United States is that Black people or people of color, African Americans, tend to have a lower HDL. And that's the narrative that's being pushed around here in the United States. Now, because they say we have what we call apolipoprotein A1, now we have a deficiency in the apolipoprotein 1 gene that we don't code, that gene don't code for that. And that's why if you tying up everything back again, when we talk about the epigenetics, right? The food, the environment, stress, and everything that you have tend to affect the way your DNA expresses itself. So that the narrative here was that Black folks, we have a deficiency in what they call, we have a mutation in the gene, apolipoprotein A1. And that gene is expected to process enzymes that give you high HDL. That was what the narrative is. But I'm telling you, I read through to find out why is it that we, people of color, tend to have that and nobody else does have that. Now, looking deeper into this, and what I'm telling you now is still very new in the literature, a lot of people don't know that the kind of sugar that is produced in some of these GMO-derived products actually reduces the HDL. So what that means is that it actually affects the enzymes that the apolipoprotein is expressing. So the HDL is less. It also increases your risk of diabetes. So drawing that down to us as a people, especially those of us who are in Africa, consuming those kind of food, and coupled with the fact of our lower, what do you call it, our sedentary lifestyle, meaning we're not as active as we used to be. You know, and I often joke, I said, when you want to go see grandma, you get up to go see grandma. These days, you pick up the phone, grandma, how are you? You even FaceTime grandma. You don't get up to go see grandma anymore. Most people tend to have a sedentary lifestyle. And unfortunately, I said this one in a gruesome and hard-feeling way, that here in the United States, that parents have seen their children die out of the cause of obesity, diabetes, and increased cardiovascular disease. Here in the United States, Blacks constitute about, some people say 13 to 15% of the population. But guess what? Blacks are 34% higher. Blacks constitute 34% of those who are on dialysis, meaning their kidneys have failed. And I can say it again, the number one cause of kidney failure in the world is diabetes. The number two cause of kidney failure in the world is hypertension, and they both have both. So we've seen our young children ending up having strokes, ending up on dialysis. And guess what? Once you're on dialysis, the number one cause of death of those who are on dialysis is cardiovascular disease. So you can tie all of this round to those two components as well.
Yeah.
Where we are right now in Nigeria and the entire Africa was what America was in the 1980s. We're heading there. We all have to get involved in this to stop.
Do you think that is so though? I mean, because I would say it's a little different. I mean, for one, we don't, where we are now, we don't have anywhere close to the healthcare America had in the 1980s or whatever it is. So I wouldn't say that's a good comparison. I wouldn't say we're in a good comparison at all.
When I said that, at the onset of diabetes and the onset of the cardiovascular risk of diabetes of diseases in our community, where the US was, that's where we are. Meaning we're in the nascent, the early stages of it. Now,
That's bad. That's really, really bad news because
it is unfortunately.
the infrastructure.
I'm sure you saw that when I was on NTA, I think a couple of years ago, 2018, when I talked about, diabetes and how it's affecting us as well. And from then on to where I am now, I've learned so much more that things that we need to truly pay attention to and begin to advocate. Um, and one of the things I saw when I came to Nigeria, which was quite impressive, then was that I saw even in the marketplace, people walk around with glucometer, checking finger sticks, even in the market, and making sure that people check their sugar level, which is really
Fantastic.
important. Which is
Fantastic.
really, really important. Uh,
Fantastic.
one of the things that really protected us back in the days, and I'll tell you this, was the sun. And you tell me how the sun is protecting us. Living in a tropical area was protecting us from a whole lot of things. Because from the sun, from our skin, we eventually produce vitamin D. And vitamin D, one of the reasons why we survived COVID, because what it does, it actually auto-regulates the innate immune system that we have, meaning it keeps our immune system on the down low level so that it dampens whatever adverse reaction that we can get from that. And that's why it's so important with the sun. Now, if you look around, those people who tend to have heart diseases and cardiovascular diseases, because we now know that diabetes, cardiovascular disease is all out of inflammation. Everything is based on inflammation. The natural inflamed state that your body is, the chances of you developing cardiovascular disease, because the vessels get thicker and harder and less compliant.
Yeah.
Now, those who tend to have those diseases, they tend to say, oh, it was a disease of the rich, right? Because if you look around, most of those rich people, what did they do? They live in air-conditioned houses, drove in air-conditioned cars, and work in air-conditioned offices. And when they go for businesses, everything's all air-conditioned. So they never got to see the sun. And that was a big issue as well. And if you look around again, those who were most affected with diabetes, with what do you call it, COVID, were the same set of people who never had or had very low vitamin D levels. Now, drawing that inferences to vitamin D and how important the sun is to us as a people. Vitamin D, a low vitamin D in pregnancy has been shown to increase the risk 3 to 4 times risk of diabetes in pregnancy. So,
you mean diabetes in the child developing diabetes or the woman developing diabetes after pregnancy?
No, the woman developing diabetes while she was pregnant.
Okay.
And we know that a woman who has that gestational diabetes or has diabetes when she's pregnant, which is gestational diabetes, has an increasing risk of morbidity and mortality for that baby. So that baby is consumed or what do you call it? Grows in an environment of sugar with pro-inflammatory states.
Yeah.
And it affects the heart of the baby, as we know, because the baby comes out big and everything else, and affects so many other things as well. So you find out that the environment, again, the vitamin D, the sun that we live in, plays a huge role. And that's why when those of us who live back home, and come live in temperate areas. Right now is winter. And how much time do we see with the sun? Less.
Yeah,
And if you look, right, we don't get the sun that much.
even if we're out in the sun, we know that the tilt of the earth during the winter makes it so much that you can't even if you go out in the sun butt naked, you're still not going to make vitamin D because of the way the rays don't travel as well during the winter.
Correct.
So
And
that
I use tying up to what you just said. If you look around here, when we talked about diabetes, the incidence of diabetes and cardiovascular disease is much higher in Black people. And who, compared to the Caucasian, 17% compared to 70% in the Caucasians. If you look around, who are the people most likely to go out naked in the sun, even here in the United States?
that's always my problem. That's one of to me, oh, that's one of
It's
the
still
great
the white
mysteries.
people
It's the
still
white
go
people.
out and get the sun.
Yeah.
Meanwhile, us
We
Black
run
folks
away.
in the US, we run away from the sun. You know why? Oh,
Why?
I don't want to get darker. Jeez,
Yeah.
you're already dark. You won't get any more darker than that.
How much
And you
darker
have,
can you possibly get?
right.
Right?
And
It's
meanwhile,
really fascinating to me.
guess what? You see, one of the things that we must also advocate for, and growing up in Nigeria, we're taught that early morning sun, you come out and get the early morning sun, right? I'm sure you heard that. Those are the sun that were good for you. Yes, because that narrative and those books were written by Caucasians for Caucasians. Guess what? Because the low melanin of the white folks, they don't need big, heavy sun. They need early morning sun, otherwise they get burnt. Right? You and me, we need midday sun, not early morning sun. For
Yeah.
us, because we're so melanated, we need a heavy amount of sun, and we have, thank God for melanin protects us. So we don't need the early morning sun that they used to say. So that's why talking about medicine, we must draw medicine and draw the conclusions and inferences that would affect us as a people directly, and moving away from the previous narratives that were written by those who were not people who look like us, because those studies were not done on us. How many of us are in those studies? And I even say this, even the tablets, the medications that we take every day, if you look at the studies that were done with those medications, how many of us were there?
Yeah.
1%, 2%.
Yeah.
So how the heck do we know that those medicines really work for us? We don't,
Yeah.
because we're not involved in research, we're not involved in those stats, and we don't even keep records anyways. So
Yeah.
there's a whole lot of work to be done. And that's why we must speak up. And in speaking up, we must raise young ones who will stand in the gap for us. Because otherwise, we'll continue to fail and continue to do bad. And I'll say this before you go on to the next topic. Understanding what diabetes can do to the cardiovascular disease. If you live here in the United States and you have diabetes, you have a 48% chance of dying living with diabetes in the United States.
Dying
If you
when?
live in Europe, 48% chance. If you live in Asia, you have a 58% chance of dying if you have diabetes. Guess what? If you live in Africa and you have diabetes, you have a 76% chance of dying. One, because diabetes is new to your DNA. You have not adapted to the disease yet. Three, we barely even understand the disease, how it is with us first. Four, we don't have the medications, we don't have the structure, we don't have the systems, we don't have nothing. So the emphasis that has to be done in our community is primary prevention. And that means we going back to our roots, eating the things that our forefathers ate, the things that we grow, the things that our DNA understand, and the things that will help preserve and save our lives. Now, I'll tell you this. If you look back a few years ago, when you were growing up as a child, how many times did you eat sweets? Our people ate more bitter cola, bitter leaf, bitter this. And those have interesting anti-inflammatory effects. and anti-metabolites. Those are the things that they have. With all these sweets and imported sweets and all the things that we live in, my dear, my brother, those are pro-inflammatory factors, and they increase your inflammatory state in your body.
Mm.
So for us to live well and live adequately and not see our children and grandchildren die in front of us, we must take this seriously and go back to our basics and eat the foods that we produce and the foods that we're used to. Period.
Absolutely. Absolutely. Well, very well said. Very well said. Well, that's a lot. Very well said. This is really good. But so we have to break this down, make it so. All right, I have a couple of thoughts now. Yinka, please just because we've done enough for almost 2 now. So what I'm going to do is I'm going to just hang with me here. All right, folks. All right, folks, you've just listened to a heartfelt, a very solid expounding of what's going on with regards to cardiovascular disease in Africa and what we need to look out for by Dr. Aluya. So thank you so much, Dr. Aluya, for this. We definitely need you to come back next week for us to continue to discuss this because there's so many things we need to unpack. But in the meantime, folks, I'm going to say, take care. Please, I hope you are taking notes. Make sure there are at least 2 or 3 things that you can take from this that you can apply right away. And let us know. Send us your questions, send us your comments. Let's see what we can expound on further this year. But in the meantime, take care, God bless, and we shall see you next week. Bye. Okay. All right. All right, welcome again. Hello, everyone, and welcome to Your Health in Your Hands. I'm Dr. David Ajibade with the Brain and Body Foundation. Last week, we had Dr. Aluya on to talk about diabetes, hypertension, and why this is a growing problem in the developing countries, especially Nigeria. And so we have to, he really, like I said, he made a really heartfelt plea to us that we have to, as doctors, but also as lay people, we have to take this thing more seriously. So without further ado, I want to say welcome back to the show, Dr. Nelson Aluya.
Well, thank you. It's a pleasure to have me come on again to discuss the issues that affect us and what we need to do and what steps we need to do to preserve our lives and livelihoods. It's a pleasure.
Absolutely. So we're just going to jump right back into it, and we're going to be discussing a lot of the other things that you introduced last week, and we're going to take it, and then hopefully run with it. Okay. So question number 1. All right. So question number 1. Okay. Now, what I'm going to do is that we're going to go back to some things that you said earlier, or the question I asked, because if you remember, initially I was asking you, what are some of the genetic reasons? Because we know, and I think you went on to talk about the environmental reasons. I think you focus more on environmental reasons like the food and the sunlight and all those other things. But in my mind, I was like, well, the environmental and epigenetics play a role. Yes, I know. But if a child in a grammar school in Elisha, for instance, is having hypertension and diabetes, and they don't have access to fast food like they have fast food over here. So why is it that these kids are having hypertension and diabetes without doing the same things that these people in the US are having? I mean, it has to be something beyond epigenetics, beyond environmental, the physical and environmental climates that is causing these kids in Elisha to have these problems. So I was hoping that we could discuss. I was hoping that we could discuss it. You pointed out a few things. One of them is the HDL. We tend to have lower HDL. Another thing is vitamin D. Well, yeah, another thing is vitamin D, because those of us who don't go out much, we don't have as much vitamin D. So I want us to discuss that, and this segment will now be part of the first segment once you discuss that. some parts of the first segment will now be pushed into the second segment. Sorry. I hope you understand what I'm saying. And I like the fact that you changed your shirt, so which is very good. I would not have thought about that. So thank you for taking your jacket off. So it truly seems like another show. All right. So Yinka, go. You will now what we're going to talk about now, you will now cut it out and put it in the first segment. All right. So let's talk about Dr. Aluya, let's talk about the genetic reasons why Africans, Blacks around the world are more prone to these conditions like diabetes and hypertension.
Well, I'll tell you this. We need to do a whole lot more studies. People who look like you and me, who are in the medical space, need to get involved in the studies that affect our people and begin to draw these lines that would, link up all the dots that will connect our genetics as a people, the environment that we live in, the food that we eat, and other social issues that affect us as a people as we draw them down to the diseases that affect us. In this segment, I'll take it in this form. One of the profound things that they're talking about lately, before we go down to the other genetics of it, is climate change. Climate change is affecting a whole lot of things, far more than a lot of people would even think. From diseases to the social, economic, and psychological factors of climate change. They just had COP28 recently in Dubai, where for the first time in 20-something years, they talked about the health implications of climate change. Because it is affecting us as a people. Now, why is it affecting us? Well, I'll tell you this. Those in Africa contribute about 1 to 2% of the greenhouse effect that causes climate. 1 to 2%. But the effect on Earth is about 45 to 50% effect. So you can imagine what that is doing to us, where we begin to see increasing changes in our environment. There's a correlation. I'm sure some smart people will look into this. A correlation between climate change and increasing diabetes. There's a correlation between climate change and infectious diseases that's taking place in Africa. We'll begin to see that.
This hasn't been proven, correct? This is just hypothetically. Okay, I'm going to jump in again. We want to talk about genetics. We have to get to the points because that has to be a segment that has to be answered. So when I ask the question, the person on TV watching the TV is waiting to hear, okay, well, what is the genetic things?
Well, I'll now bring down.
We've not done that yet.
Right. I'll bring it down to the genetics and how the environment is affecting everything.
We need to get to that as quickly as possible. We can talk about climate change after. Good. But we need to, so he doesn't lose interest.
Right? I get you. Right. So now the genetics component of it is this, and in the first segment we talked about epigenetics, how the environment is changing our gene. Now, that particular gene models that are prone to Black people having these issues than anybody else? No, none has been really proven. But one of the things that have been proven recently, and I'll tell you this, and I'll give you inference, because I tied up cardiovascular disease with chronic kidney disease, right? And chronic kidney disease, and people ended up on dialysis. Now, we inherit a gene, especially those of us who are from the West African section. It's called the APAO1 gene, the APO1 gene. Now, the APO1 gene defect that was described about 10 years ago in the literature, but it's beginning to have its effects in the medical aspect of it. Why is it that? Because one of the questions I told you that in the US, blacks constitute only about 15% of the population, but blacks constitute 34% of those who are on dialysis. Why? Because we begin to really find out that we inherit the APO1 gene and a defect in that gene. The defect is on the G1 and G2 mutation that once it's affected, you have a 20%, 20 times risk of developing chronic kidney disease and ending up on dialysis. That gene we inherited from Africa. And guess what? We carry that gene the way we carry sickle cell. It's the same pattern. Here in the United States, it is said that 15% of blacks in the United States carry that gene mutation here in the United States. That increase our risk of ending up on dialysis or chronic kidney disease. But how many of us have that? How many doctors who are black even are discussing this? How many of us know that? So,
well, if they know that, what would they have to do? What would you advise them to do?
So,
I mean, they can't do genetic tests everywhere, right? So
no,
what?
But guess what? You see, that's where the advocacy comes about. And I'll give you a historic perspective of it. The first time that a disease entity was described with genetics was actually done for sickle cell. A lot of people don't know that. And it was done for a young gentleman who came from the Caribbean and was found to have multiple aches and pain, yellow eyes and all that, and eventually they described it to be sickle cell, right? Now, from that time to now, they've been works on gene and how it affects diseases, correct? Now, what happened to the US eventually? I can't remember what year now, but eventually here in the US, every child that is born, that is African American, they screen for sickle cell. Day one, as you're born, right? Because for years, they never did that. Some people advocated for that so that we can know who is born with sickle cell so that we can intervene early enough. When we talk about intervening, meaning we put them on medications that will protect them from with folic acid, as you know, put them on multivitamins, put them on zinc, put them on antibiotics, and give them medication and screen their brain for strokes, correct? Now, with this issue, it's still new. We need advocates, hopefully in the future. Maybe somebody who's listening to me now, somewhere, sometime, would advocate to a point where every child that is born here in the United States will also be screened for the APO1 gene. So that they will take early intervention. You know why? Because if you know that your family, look around. I'm sure people who are looking around, who are hearing me right now, and I've spoken to some people, you ask them, multiple members in the community ended up on dialysis. Even in Nigeria, multiple members of the family, and they don't even know why. They don't know why. So if you find out that you carry that gene, or like we do sickle cell, so you don't marry somebody else who also carry that gene, right? So that you don't give birth to a child who will not end up with a full-blown disease. That's one.
Okay. That's one. Okay. Well,
two,
then but what would be the lifestyle things or things that they would need to do?
Correct. Meaning you have to make sure that you don't become obese.
Okay.
2, 3, you have to screen yourself for diabetes. Because if you carry that gene and you not have obesity or diabetes or high blood pressure, guess what? That risk is quadrupled. The risk at which you end up on dialysis is so much more and higher. And I'll give you a typical example. Something happened recently that a lot of people never paid attention to. And I'm sorry I'm going to bring that up, but we need to draw inferences to things that we can relate to.
Yeah.
And that's the child of former Senator Ekweremadu, right? We had all the whole issues that happened, that she ended up, they wanted to look for a kidney transplant for her and all that and all that. And the whole story that eventually happened. One of the things that really bothered me, and I said, one, she's female. 2, she's young. Why would a young female who even live in the United States, in the UK, ended up on dialysis or had chronic kidney disease? Why? That's a question I really paid attention to. I never knew why. But then when I sat and I listened to her video, people should go back and play. She actually did say so. She said it. She said, I heard the gene, the APO1 gene, that
She
put me at
mentioned that.
risk. Yes, that put me at risk for chronic kidney disease and ended up on dialysis. She actually did say so. So that's somebody who lived in the United Kingdom, who's exposed to the forefront of technology and all that. And she knows that. How many of our people back home carry the same gene and they have no idea? So what that means is that once you know you carry that gene, you have to take active steps to protecting yourself from those risk factors that make you end up on dialysis. Diabetes, high blood pressure, you have to control and all that. And then we know we have some medications that can protect your kidneys. So often enough now, for every Black person who comes to see me, you see me for the first time, I will screen you for protein in the urine, and I'll screen you for microalbumin in your urine. If you're coming back for your annual well check, which I always advocate that every person should have at least one health check every year. And in that health check, things you need to check for: blood pressure, make sure your pressure is controlled. If it's not, what should you do? Cut back on the number of salt. That's another story, salt and genetics that put us at risk for high blood pressure. We can talk about that another time. But you screen for diabetes. What is your A1C? Do you have an A1C less than 5.7 and less, meaning you don't have diabetes, or you have a 5.7 to about 7 or 6.8 that puts you at a pre-diabetic level, or you have 7 and above with symptoms, so you need to know what's your A1C status, know what your diabetes status. If you're pre-diabetic, you have to take active steps to preventing this. Alcohol, all of those things, you have to stop. Today, I saw a patient last month, and I did the annual check, and I looked at his kidney function, the GFR, which is the glomerular filtration rate, the rate at which your kidney filters, on a common terms, how your kidney filters your body from waste. That number ideally should be 70 and above. Now, and I looked at his own was 54. And I said, my brother, he's African American. I said, your kidney function is deteriorating. So I took a picture for the last 2 years, what his GFRs look like. And I gave it to him. 2 years ago, it was about 95. It slowly came down from 95 to 86 to 70 something. And by June this year, it was about 75. By October, it was about 65. And I draw it down, it came down to 54. He was shocked. He said, Doc, I know what happened. I've not been disciplined in the way I drink. I've been drinking a lot. Because I just feel my head is, I feel stressed, I feel whatever, so I drink. I said, okay, fine. You're gonna
How old was he? How old is he?
He's 51. He just turned 51. But he looks healthy.
Our age mate.
Blood pressure is controlled, everything else is controlled, nothing else. So, and I said, listen, because he became frightened. Of course, we corrected his vitamin D and everything else. He's on vitamin D, a few other stuff. And I said, lifestyle modification, lifestyle changes. You have to do this. Lose weight. He was obese. Cut back on the alcohol, the beer, the drinking. Because once you drink beer, the beer and the metabolism of the food actually goes down to your waist area, to your belly, to your gut, and increases your weight. And once your gut is increased, the increased risk, cardiovascular disease and inflammation is so much higher. So he came back to me today. We did the blood work. I did the blood work about a week ago. He came back. His GFR that was 54 is now 86.
Oh, wow.
He was so happy. And I said, you see the difference? He said, Doc, I see the difference. And all I did from November till now was lifestyle changes, cut back all those food that I eat. I cut back the alcohol stuff, and I started exercising and I lost weight. That's exactly what you can get when you have lifestyle modification. So for those young men and women who are drinking themselves up to stupor all the time, you're damaging the kidney, you're damaging the liver.
Yeah.
And those are the things that will put us at risk. So if you have the kidney disease that we know, which we know, I don't even know if they screen for for the genetic defect in Nigeria yet. Even here in the US, it's still very few. I've been asking for it. I saw a lady who, for some reason, she's 64. Her kidney function has just been deteriorating. Blood pressure is controlled. She has no diabetes or whatever, and I could not phantom it. So I said, you know what? I'm going to screen you for this gene. But I asked, I know the mother. The mother is a patient of mine. The mother is 86 years old, healthy, no issues. So I said, how about your dad? He said, Doc, I'm sorry, I don't know my father's history. So that could be coming from the father's side. And she had not. So I screened her. Guess what? She has a mutation, G1, G2 mutation of the gene. So these are issues that we must begin to pay attention. And one of the things I hear from Nigeria a whole lot, which is disturbing, the increasing rate of people end up on dialysis, kidney failing, and all the things that's happening to them. So these are genetic, issues that are affecting. Again, the APO, apolipoprotein 1 proteins that we also carry, and what is affecting that, and how we need to address these issues. So these are big. But then the most paramount thing that needs to be done, we must raise young ones who are like you and me, and I speak about that here in the United States as well, who will go into clinical research, who will
Mhm.
stand in the gap for us to tell us these genetic mutations that are happening here and there, what does that mean to us? How will it affect us today? How will it affect our children's children, so
Yeah.
that we will not see them die or end up with severe debilitating diseases, including cancer as well. I mean,
Yeah.
here in the United States, we begin to see a whole lot of cancer issues in women, breast cancer. You
Mhm.
understand? Breast cancer increase. And then talking about that again, in my studies back in the days, I've always had this curious mind. I schooled in ABU, and in Samaru area, when we did rotations for surgery and all that, we used to see young women who came in. They're breastfeeding the child in one breast. They have a fungating breast mass, meaning cancer has eaten up the breast so badly on the other one. But they have a baby and they're breastfeeding. So that was incongruent with what I read in the books. So how is it that this young girl, who is not up to 40, childbearing age, she has cancer? And she's still up because she's still able to breastfeed. Why is this happening? I never understood that. You understand? And I was bewildered. So when I came to the US, I started going back and looking and reading and all that. And even in the US as well, I began to realize that prostate cancer, the teaching was that all men 80 and above, you have 88% chance. 88% of men 80 and above have prostate cancer. Well, it's not going to kill them, but they will die from something else. But we begin to figure, even back home, and I saw that too, that people who were younger, who had cancer, had very aggressive cancer, and they died. And here in the US, all around what I've moved around, I noticed that the majority of people who had very aggressive cancer were people of the Caribbean, meaning Jamaica, Haiti, and all that. And I used to wonder why. So I did understand why, but I knew there has to be a connection somewhere, but I didn't know what until I started digging more. And what made me dig more? Well, one of my colleagues, who is also a doctor, OBGY, developed prostate cancer. And he run in the family. He's from the Jamaican, descent. So I began to read and then tied it up that there's a genetic, I can't remember, P24 gene mutation that we as people of color, Black people also inherit, that's also be tied on to breast cancer.
Oh,
And the
really?
breast cancer aggressive breast cancer and aggressive prostate cancer. And guess what? That gene has been tied up to northern Nigeria.
Northern Nigeria.
Voila. So it began to explain some of the things that I was curious about, that why was I seeing that and why was I seeing that here? And here I ran a cancer clinic, a primary care cancer clinic where I took care of cancer patients who were doing chemotherapy and all that. I was seeing younger and younger and younger men and women with breast cancer who are Black here in the United States. And we begin to wonder. One, again, stress is a big issue. Stress. The stress that we're going to here in the US and the stress that's happening in Africa with increasing modernization, where the role reversal is taking place. Family social dynamics. A lot of homes, women are becoming breadwinners that they are here as well. So all of that has been tied up to increasing risk again of cancer. These reports are written out there. We just have to look and take steps on how to mitigate this. You know, the gene is there. Only God knows if they're inherent, but are they turned on by something? And what is turning those genes on are the things we need to pay attention to so that we focus primarily on primary prevention, because that's what the US is doing now. They're putting more money in primary healthcare and primary prevention.
Wow. Oof, we have a lot of work to do. We have a lot of work to do. Okay. So we've mentioned some genetic things with regards to the cancer gene, I think you said the P24, whatever. I've never heard that before with northern Nigeria. And then of course we talked about the APO, is the APOA1.
Yes.
APO1 gene, the mutation.
APOL1 gene. APOL1 gene.
APOL1 gene.
Yeah.
And when we need to go back and look at those APOL1 gene, which makes you more susceptible to kidney disease and therefore to dialysis. We also, you kind of touched on our tendency to be more salt sensitive. We also found out too that platelet wise, we tend to have higher platelet levels than white people do, which tilts us more towards coagulation states, which is one.
Not just that, you know that for instance, inflammatory mediators, like we talk about, are one, and we also know C-reactive protein, CRP, and ESR, right? Now, other inflammatory mediators that you can tell if somebody is an inflammatory state is ferritin and platelets. So if somebody has an inflammation going on right now, if you check the ferritin level, if you check the platelet level, they're high. They're really high. Okay. If you check the CRP is also high. The ESR may not be high immediately, but the ESR kicks in when it becomes a chronic inflammatory state. So platelets that we tend to have, yes, in itself, is a depiction of the inflammatory state that we'll begin to head on to, which was not what we used to be. It wasn't what we were, what was, what we were known for. But because as we increase and eat those pro-inflammatory foods, inflammation will become a big problem with us.
So we need to find out what are the anti-inflammatory foods and start to really drive home this point to people that you've got to focus. I mean, it's very hard to, let's be frank.
Eat your natural food, basically. Eat the food that comes out of our earth and our grass. We need to, and that's why policy issue has to come up. We need to reinvest in farming, period. We need
but don't forget, a lot of our foods has a lot of starch in them. So that is a problem itself too. The pounded yam that we're eating,
I'll tell you what.
These are pro-inflammatory foods as well. So you don't want to forget that. And we don't eat enough raw fruits and vegetables. We eat raw fruits, but raw vegetables is almost a complete anathema to us. We don't eat raw vegetables. Where's some of these?
Not anymore. Because you see, I'll tell you this, not to stop you. Look, when people talk about we eat a lot of starchy food, yes, we do. But so also was your great and great grandfather. That's what they ate. They never had diabetes. They live long. That's what
Because they were active. That's because they were super active. They were super active.
they were super
But
active.
we're eating the starchy foods and we're not active at all.
We're not active, but we're supplementing those kind of food and the protein that we eat. I remember that stuff. It's something we need to look in, and people need to read into it. Um, that is affecting the way we metabolize glucose.
Yeah.
And that is if you go back, because I read through all the history of wheat, how wheat came about. Wheat was actually initially first in on records was described in Afghanistan way back. We're talking about BC, and the wheat that they had was this high. It wasn't not high at all. And then when they started genetically modified wheat, the wheat came up to like 6, 7 feet tall. And they're like, oh my God, this is not too much. And then wheat could produce maybe once with 10 leaflets in a year, once or twice a year. And then by the time they alter them, they produce 50, 100. Because again, they needed to feed more mouths. They needed to, preserve them. So, technology is an issue. It's causing harm, but again, technology will have to use to solve our problems, and that's where we are. And hopefully, with with the onset of AI and all that, we will use these tools to truly understand, especially for all those of us, where we can take our DNA, use AI in analyzing those DNA and what the genetic mutations that are there that would interpret itself to the disease and the possible diseases that we would have as a people. Because the future we're heading towards is precision medicine. So that I can give you a blood pressure pill, but the blood pressure pill that I'll give you, I will run it against your genetic profile and it will tell me which of the class of blood pressure pill that will work better for you than another group. And hopefully that's why again I keep saying we have to get involved in the research. We have to get involved in the policies and politics. We have to get involved in the advocacy of healthcare and the economics of healthcare.
Absolutely. Well said, Doc. Unfortunately, we run out of time again. So clearly we have to bring you again next time. So we just continue the discussion. But those are very salient points you brought out, and I hope our viewers take a lot from it. Thank you so much for this.
Thank you. My pleasure. Thank you.
All right, folks. So again, thank you for joining us. Remember to stay tuned every week at 2:30 p.m. on Wednesday. We are also on YouTube, so these videos will be archived on YouTube. Just go to our website, brainandbodyfoundation.org, and you will see those videos there. In the meantime, take care. God bless. See you next week. Bye. Awesome. Wow. Golly, man, we're in trouble, though. We are in trouble. I'm telling you. We are in trouble, my brother.
Listen,
this is
you have
got this. All right, start again about the nurse who discovered or who.
Yes, no, that the reason for advocacy, why it's so important, because the individual who started the onset that led to the screening of sickle cell in the United Kingdom was done by a nurse who saw the need to advocate for screening sickle cell in the UK. Because at that point in time, it was a black man's disease, just like it still is. But guess what? Nothing was being done about it. So she saw and treated a lot of young babies, young adults, young kids who came with signs and symptoms of sickle cell, and they were dying. But there was nothing in the UK to do that. And of course, her work in that led her to leave the United Kingdom because there was basically nothing being done, and came to the US to come learn about sickle cell. And if you remember, I said that the first delineation of a disease, a genetic delineation of a disease anywhere was done for sickle cell, but research wasn't done. So she came, learned about sickle cell, what sickle cell was, and what they were doing here in the United States, and then went back to the UK. And she, with her advocacy and obstinate tendency and fight for her people, went on to set up the first sickle cell, what they call it, treatment center, and eventually screening that took place in the UK. And that's her work, her life work. And that's why she got all the awards and accolades that's been taking place in the UK. So when we talk about sickle cell in the UK, that's what she's done. And that's why she was recognized recently, even when Prince Charles was what do you call it, coronated and all the whole stuff. I can't remember her name now, but if you look at sickle cell history and sickle cell screening and advocacy in the UK, that's what her work was. So why am I saying this? That it does not take the efforts of everybody to create that change, a system change. It's often one person who is obstinate, determined, willing, that's a life work for her to make sure that is done. You cannot be tired when you have a mission that will save lives and livelihoods. So
that's what we're trying to do with this whole our project SCD Nigeria. I don't know if you followed it, but we found out that simple things like vitamin C, vitamin D, and zinc, which we put together in one capsule in specific doses that we're distributing throughout Nigeria free of charge. And the results that we've been getting have been absolutely phenomenal. And so our goal is to advocate for the inclusion of these as standard in the policy. We're talking about policy.
Right.
Doctors are only giving folic acid these days to kids with sickle cell disease, folic acid and antimalarials. We have now, we've done a study in Lagos by adding vitamin D alone to folic acid and antimalarials, and the difference in the health of these kids is significant. But so we have that study done, but then we also have these 25,000 bottles that we're distributing all over the country that have the vitamin D, vitamin C, and zinc, like I said, in specific proportions. And again, those are getting results as well. So we're trying to come at it from different angles. The end result is that doctors should be prescribing these things on the table. When they meet the parents or the kids who have sickle cell disease, this is what they should be prescribing, not just folic acid. And that's what I'm going to need people like your help for, because we want to distribute. We want partners in Nigeria that we can distribute these things to, who can responsibly, they won't sell it, but they can distribute and help us take records. So do you have any ideas about that for us?
Well, I mean, first, I often say change often comes, but by the determined will of a committed few. Change often comes, but by the determined will of a selected few. So what that means is, as you stand in the gap for what you do in sickle cell, and you want to get it done and put it out there because you know it works. So you have to be obstinate about it. So whatever resources that would take for you to get there, you have to. Meaning, you do your due diligence, cross all your T's and all your I's, which you've done. Then you look for people who would hear you, who would most likely understand the message you're pushing out there. Meaning, one, those in government, NGOs, those in the diaspora, and you must connect the dots. And as you connect the dots, obviously sometimes it takes money. You have to look for the resources to do that. And the resources that most people talk may not be as big as most people think. One of the things that we as a people, when I mean me as a people, Black people, we want to see something succeed first before we even venture it. Because we have an innate inability to trust, innate inability. So what we need to do is first, you prove that it's doable, and you show the evidence that's doable and has been done. I hear you.
So now, check now. That has already been done.
Right.
That has already been.
So what that means is this. You go on knocking on doors. All the doors we just talked about. Listen, you knock on the door on the senator today. The senators do not listen. You go into another door of another senator. You knock on that door. It doesn't open, you go onto another door. and then you will eventually get a door that will open up. It usually does. And
No,
that's what
I
it
mean,
is.
yes, we're doing that, but I'm asking you specifically. Do you have any people you can relate us to? Because I'm all what you're saying, I'm familiar with that. We met like 2 years ago, I think. That we had ECAU together and all that. I've done a lot since then. Since the last time we talked, as you know. So
Right.
what
So
you're
one
saying,
of the
I
things
can relate.
I would that's also really great, that would help open up doors and channels is a write-up. You have to write these things up.
I
Uh,
have. If you want me to
I
send it
don't
to you, I can
know,
send
and then get it published in the right places.
it.
And that's just what it is. You see, networking matters a lot because
Yeah.
by you meeting one person who has an access to something else, you'll be shocked. You can get published in the New England, not just the New York Times.
Mm.
Because if you publish in the New York Times, a whole lot more people will read, and you'll be shocked. A lot of the time, the doors or the people who open doors for you are not people who look like you.
Yeah, that's true.
They are not people
That's
who look like you. So
that's true.
because the chances of people who open doors are people who not look like you may have to target those who don't look like you.
Yeah.
For instance, there's a national press association here in the United States. It's an association of people in the press or media industry who are black. They have publications. So linking up with some of those, and maybe I'll have to, link you up with some of those and have them publish one of those things in one of their big magazines that people will read and listen to. And that's how those open up.
Yeah.
I was listening to a program recently. What's this woman? Was the CNN?
Come on, Paul.
Is it Sani Badawi or something? Badawi or something? I can't remember her name now. It's on the minds of Nobel winners, Nobel Prize winners, the minds of a Nobel Prize winner. She got about 6 or 7 of them on the round table who won Nobel Prize, this past year. And
Okay,
had
the
them,
lady who looks like she's Arabic or something, almost.
yes, I think she's one of those places. But but one of the things I took out of that was one lady who worked on something for 40 years. 40 years. That's her whole life. 40 years she worked on that. And I'm sure for you to work on 40 years or something, she failed. She was obstinate. That's the word they used about her in ensuring that she gets the result. And sometimes the result you're expecting is not a result that eventually will make you a Nobel Prize winner. Something else out of your failure is what becomes the result that would make you significant in the space that you've taken. And that's what it is. And now they're expressing that and interpreting that into the medical field and solving problems on a day-to-day basis. One of the other person who was there was what's this woman name? Oh, oh my God. The woman who worked on mRNA technology.
Oh
Uh,
yeah. Yeah. CRISPR.
Catalina Caraco. Catalina Caraco. She's
Oh,
from
okay.
UPenn. Catalina Caraco. She's Hungarian. She came in the
Okay.
US in the 1980s. She worked on the mRNA technology all through her life because the intent was, again, mRNA determines how the enzymes are expressed
Mm.
because the DNA codes for mRNA and the mRNA determines how the enzymes are expressed. And of course, the
Yeah.
environment can alter the mRNA. So what she did, she wanted to use the mRNA technology in solving metabolic diseases, meaning diabetes, obesity, high cholesterol. That was our intent.
Mm.
But of course, when COVID came, we threw everything at COVID except the kitchen sink to ensure that we get treated. And of course, they went back to using the MRI technology, and we see what has happened. And it short-lived the time it took, the usual 6 to 7 years it takes for you to develop vaccines. MRI technology shortcut it for a short while. But if you go back to her history, she failed multiple times because when she first used it and worked on mice, the thymidine component in the DNA that coded for her to preserve the DNA, when she gave it to mice, the mice died. They bled, massive bleeding. They all died. And she didn't have an answer for it. So she went to one of these, what do you call it, symposium, a conference. I met a young African-American guy who was working on something. And she said, listen, this is what I'm working on. And I can't fathom why my mice are dying. And all the research I've done, and the smart guy who was also working on something different, identified and analyzed and realized that it was a thymidine component. So what they did, they took the thymidine out, she injected, mice no longer died from that. And then the next thing is to preserve it and see if, because it has a very short what do you call it, half-life, you know. So for her to be able to preserve it, it was difficult. So again, she met some, I think, Langerhans or something, you know, who was disgraced in the 1970s on his, you know, paper he published on how to preserve, you know, even the food, the medications, and all the things that we wrote. He wrote the glycogen molecule, the big molecules that are used in preserving, you know, natural products. They made fun of him. He was disgraced, actually. But eventually, look at what he's done. So when she met him, she told him, and they worked together. Voila, they were to preserve, you know, Emirates to a point where it can last enough for us to use with what we have now. So this is the story of people who have, I'll use the word again, obstinate about what they're convinced about, and to continue to push for it until they get the results that they get. And like I said, often enough, it may not be the results that you're expecting that will make you a whole name, you know, that we're talking about. Talking about sickle cell, if you remember, you see what happened, the landmark changes that happened recently, I think last month, on sickle cell, where they use CRISPR, right?
Yeah, gene therapy.
On treating sickle cell. And you know the whole story of CRISPR. But one of the things that really triggered me was the first time, I think 2 years ago, when I read they were going to use CRISPR first for sickle cell. I said, ha, these people, they've come again. They want to experiment on Black people on Black disease. Because CRISPR, it's a long name, acronym for something, is where you use the technology to take away a particular DNA and replace the DNA. So it's like cutting the DNA and replacing it with something else that will come to delete that gene that's diseased. So when we talk about in sickle cell is position 6 valine replacing leucine, right? In position 6. So if they go to that position 6, take away the valine, replace it with another enzyme, what do you call it? A protein that would make that person sickle cell free, right? So I now said, why are they doing it in Black people? Why didn't they do it in all the other diseases that they talked about? You know why? Because from the first time sickle cell was described, remember what I said about sickle cell? From that time till the late 1950s, nothing was done on sickle cell. Nothing, no research, zero, because again, it's a Black man disease. But research was done on everything else that concerned dirt. The only thing that came out until the late 1950s was hydroxyurea, which they found that by mistake, it increases the, what do you call it, the fetal hemoglobin, right? That help you increase, you know, blood flow to the tissue so that people get, but then it worked. It has a side effect. It has all the things. It was not the magic bullet that people expected. From that time till 2018, zero, nothing was done. Nothing. until recently they came up with new studies and new medications and blah, 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 which now they now say, oh, we're going to use CRISPR. And I said, CRISPR, you're altering the DNA. Why would they want to use it for black folks again? But listen, they say they're going to do it. Who spoke on black people's behalf? Nobody. All right, they did it, and now we have it. Black people are shaking their hands. We're all happy. All right, fine. We're going to treat sickle cell. But what's the fallout? Do we know? What's the effect on that individual when you replace the one gene for another?
Yeah. Yeah.
Because guess what? CRISPR was not originally an American technology. It was not founded in America. It was actually done by the Japanese.
No, really? I
Yes,
didn't know that.
CRISPR was first described by the Japanese. You know why? Because they found out that bacteria, right? Bacteria get infected too. People don't know that. Bacteria get infected by viruses. Bacteria infect viruses and kill virus. Bacteria get infected by virus and kill the bacteria. So in order for bacteria to preserve themselves and protect themselves, they now coded for a gene that allows them to cut away the section of their DNA that viruses attach to. So if they cut away that DNA and the virus comes, because the virus is used to attaching to one particular section of their DNA, it can no longer attach. So they get immune. So, but they were smart enough, they realized it, they looked it, voila, they did it. And some smart guys here in Boston looked at that result and they worked on it, wrote about it, and it became a big issue. But then the technology of CRISPR, some smart guy who I don't know what happened came from China, learned CRISPR to a large extent, but didn't learn it completely, and went back home to China and genetically modified a fetus gene, coded it, desired all the DNA proteins that they wanted, and that baby was born. A baby girl was born out of CRISPR. A lot of people don't know that. A lot of people don't know that. So they genetically modified somebody who gave birth to a baby in China. So these things are out there. Read this thing. We need to know. So what's going to happen in the future and how would this technology affect us as we live in the area of CRISPR, mRNA, AI?
Yeah.
And that's why you and I must raise young ones who get into that space so that we can protect us. God forbid they create a new gene that can help eliminate who? People of African descent, blacks, or some people they don't desire. So it's important.
It's a very scary, very scary prospect.
We're living in interesting times.
Interesting times, and I'm curious to see what that child that was made that was CRISPRed in China.
That was CRISPR, right?
I'm sure that's going to be a new term, it's going to be part of the lexicon these days to see what exactly happened to